welcome to Informed in 30, National Brain Tumor Society's education initiative committed to providing brain tumor patients and caregivers with key information about cutting-edge advancements in brain tumor research and treatment. Our topic today is understanding biomarker testing. My name is Rachel Kittleson, and I'm the Director of Community Relations at the National Brain Tumor Society and a member of the NBTS Personalized Support and Navigation team. Joining us today are Dr. Linda B., Assistant Professor of Neurosurgery, Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard Medical School, and Dr. David Meredith, Assistant Professor of Pathology, Brigham and Women's Hospital, Dana-Farber Cancer Institute, and Harvard Medical School. Thank you both for joining us today.
Thank you, Rachel. I'm so delighted to be part of this segment and look forward to helping our brain tumor community learn more about this important topic.
I agree with Dr. B. It's an exciting opportunity to educate patients and caregivers about biomarker testing and what we do behind the scenes in terms of brain tumor diagnosis and treatment planning.
Because of innovation and new technology, researchers and clinicians can learn a great deal about a patient's brain tumor, how to treat it, and how to manage its growth. In 2021, the World Health Organization updated its classification of tumor types of the central nervous system to make brain tumor classifications more accurate. Biomarker testing is used to make those more accurate diagnoses that can lead to better estimates of prognosis and better predictions on how a tumor is going to respond to treatment, which can help guide what course of care a patient should receive. As we get started today, I'd like to take a moment to acknowledge that there are different terms used when discussing biomarker testing that include molecular profiling or testing, genomic profiling, or genetic testing. We will use the term biomarker testing, which are tests that identify characteristics, targetable findings, or other test results that originate from malignant tissue or blood. We are so very grateful to both of you for joining us today to help our patients and caregivers gain a better understanding of what the most common biomarkers are and what they mean for diagnosis and treatment options, and what the process looks like for incorporating biomarker testing at diagnosis all the way through results and determining next steps. With that, I would like to pass it over to our presenters today.
So before we launch into a discussion of biomarker testing, I first wanted to give a brief overview of historically how the process of tumor diagnosis occurred. Like most aspects of pathology, tumor diagnosis is conducted by comparing the appearances of the tumor cells under the microscope to normal cellular components of the tissue in which they arise, such as many of those shown here. This microscopic appearance really formed the foundation for how we made tumor diagnoses, and each tumor type had its own grading criteria, such as shown in this table below, and those assessments of tumor severity or tumor grade were then integrated with the tumor diagnosis to come up with a treatment plan and prognostic assessment, largely with fairly blunt instruments such as radiation and alkylating chemotherapies. As molecular testing technologies have become increasingly more sophisticated, not only in terms of higher throughput, but higher resolution assays, there have been a number of studies which have been able to profile a number of brain tumors and come up with recurrent genetic aberrations and biomarkers that are characteristic of many different tumor types, which have paved the way for the integration of these molecular findings into this WHO CNS tumor classification schema. So here's an example of many of the tumor types for which diagnostic or prognostic genetic biomarkers exist. And while this is certainly not the content for the talk this afternoon, I certainly wanted to take an opportunity to show how pervasive genetic testing has become incorporated into our diagnostic workup. So this really now indicates what our new workflow is in neuropathology, and we now marry quite closely the histologic appearances of tumor cells, as we always have, with molecular data to come up with an integrated diagnostic and prognostic assessment. In many cases, the molecular data is able to, in isolation, provide tumor class information. Many genomic signatures are diagnostic. Furthermore, there are genomic biomarkers that are capable of providing very detailed prognostic assessment in the absence of corresponding histologic features. And so these have paved the way, as Dr. B will talk about later in the presentation for biomarker-based clinical trials looking at advanced targeted therapeutics. So now transitioning to some of the most common biomarkers that we look at in adult gliomas, IDH1 and 2 mutations and 1p19q co-deletion are the two most important that we routinely assess. Looking at survival curves for many of the adult glioma subtypes based purely on the histologic examination, such as this survival curve in the top left corner, we can see that we did a pretty good job of stratifying tumors with different clinical characteristics based purely on their microscopic appearances. However, once IDH1 and 2 and then 1p19q co-deletion molecular markers were identified and then incorporated into diagnostic schemes, we were able to separate these tumors much more cleanly in terms of their survival characteristics. So those tumors possessing either IDH or 1p19q co-deletion, we can see do far superior to those that lack both. So now, in terms of routine workup, whenever we come across a tumor that appears to be a diffuse glioma under the microscope, we routinely assess both of these biomarkers. IDH mutations are most commonly tested by immunohistochemical means, looking at the most common point mutation, IDH1R132H, or some centers have targeted sequencing for IDH1 and 2. Tumors that show positivity for a mutation in either one of those genes at a hotspot codon are then reflexively tested for 1p19q co-deletion status, most commonly by FISH, which we'll show momentarily. Tumors that have both IDH mutation and 1p19q co-deletion are now, by definition, oligodendrogliomas. By contrast, tumors that are only IDH mutated but lack 1p19q co-deletion are astrocytomas, and tumors that lack both are frequently very aggressive IDH wild-type glioblastomas. And so, without even looking under the microscope, we can use this combination of biomarkers in a diagnostic setting to very accurately classify tumor types like we weren't able to prior. So now kind of looking at IDH mutations more broadly, these are mutations in the isocitrate dehydrogenase gene 1 or 2, which is a part of the citric acid cycle. And mutations are not exclusively found within gliomas, but many other different tumor types, such as hematolymphoid tumors and chondroid or even some sinonasal carcinomas. But regardless of setting, these mutations produce a novel metabolite, 2-hydroxyglutarate, which is not normally present in cells, which amongst its effects is responsible for aberrantly methylating the entire genome in the tumor cell. And this, amongst its consequences, leads to a block in differentiation programs, leading to tumorigenesis. Paradoxically, these mutations also confer a more indolent behavior in these tumor cells, presumably from the same mechanism. And so even though these are oncogenic mutations, they also confer a better prognosis to those tumors relative to gliomas without them. 1p19q is the result of an unbalanced translocation between chromosomes 1 and 19, and the derivative chromosome that contains 1p19q is lost from the cell such that only this other derivative is retained. So we can detect whether or not 1p and or 19q are lost from a cell by using fluorescence in situ hybridization, in which a large segment of DNA, somewhere on the order of 150 to 200 kilobases, is tagged with fluorophores and recognizes specific regions of the genome. So in this case, either 1p or 19q. And loss of one of those signals from the normal disomic content in the cells indicates a loss of both of these regions. Now, while this is a fairly sensitive assay in detecting whether or not this aberration is present, it is also unable to detect whether or not the entire 1p arm or 19q arm of the chromosomes are lost. And so more comprehensive assays are becoming increasingly used in order to make sure that there are no false positive results in 1p19q testing. So more and more we're beginning to transition to using whole genome or higher resolution assays so that we can determine whether or not a whole arm of 1p or 19q are deleted. Even though FISH is a very sensitive assay, it's something that may or may not detect focal or entire arm losses. And so a microarray analysis such as shown here, in which Each chromosome is indicated by different colored segments, and normal DNA content is here at the 0 line, and any deviations up or down from that indicate pathogenic gains or losses of material. Indicate that in this tumor type we see entire loss of chromosome 1p and whole arm loss of 19q, indicating that this tumor is indeed an oligodendroglioma. Furthermore, other glioma subtypes have fairly stereotyped copy number signatures, including IDH mutant astrocytomas and glioblastomas as well, such that in many cases we can make a diagnosis on copy number profile alone. And while many labs may not necessarily have dedicated microarray testing for brain tumors, the same data can be achieved from most commercially or academically available sequencing platforms, whether they're targeted or whole exome. So while we've talked mostly about tumors that have either IDH mutations or 1p19q co-deletion status, it's important to keep in mind that profiling glioblastomas are equally as important. While this is a diagnosis that's fairly straightforward under the microscope and has fewer prognostic biomarkers, it's still something that routine assessment can provide fairly useful. We've known that many different cellular pathways are activated in these tumor types, many of which are druggable, and routine profiling of these tumors can help us assess which biomarkers are present, if any, and whether or not this may be something that can be drugged in an investigational trial setting. Furthermore, I think it's important to understand that just because we're pretty good at making diagnoses under the microscope, we do occasionally run across cases that mimic one another. This is just an example of a large cohort in which we were profiling glioblastomas for a trial purpose, and by routinely profiling each one of these with comprehensive molecular assays, we were able to pick out this example tumor that showed a nice 1p and 19q co-deletion, allowing us to reclassify this tumor as an oligodendroglioma and get this patient a more appropriate therapy for that. So we do have the occasional case in which routine profiling allows us to catch these occasional mistakes or just very difficult cases to diagnose. Transitioning now to prognostic biomarkers, many adult gliomas will undergo analysis for MGMT promoter methylation. Methylation of any gene promoter is a phenomenon that will essentially silence that gene and prevent that protein from being made in the cell. And MGMT is a protein that essentially repairs the genotoxic effects of alkylating chemotherapeutic agents such as temozolomide, which is widely used in the therapy of brain tumor patients. And so we use a technique known as bisulfite conversion PCR to assess whether or not the promoter region of MGMT is methylated. And what this technology does is essentially changes the coding sequence of the DNA depending on whether the CG dinucleotide is methylated or not. And PCR primers specific to either one of those sequences can be used to show us if that region in the tumor is methylated or unmethylated. And as I mentioned, this is something that is routinely performed for all gliomas in the adult setting. Transitioning now to talk briefly about pediatric low-grade gliomas. These are the most common childhood CNS tumor types. They occur in a wide variety of histologic subtypes and occur throughout the CNS overall. But unlike adult tumors, they really have a fairly promiscuous array of genetic alterations that can be seen in each different histologic subtype. And so many of the biomarkers in the pediatric setting may not necessarily be diagnostic or even prognostic. However, unique to pediatric gliomas, these low-grade gliomas very rarely transform like they do in adult gliomas, which makes them extremely amenable not only to surgical resection, but also to targeted therapy. And these tumors are unique in that the type of signaling pathways that are preferably altered in them belong to the MAP kinase pathway. And this is a pathway for which there are a number of targeted therapeutics available that are highly effective in this setting. So taking, for example, the mutation V600E in the BRAF protein, this is a highly recurrent mutation that's present in many different tumor types, not just gliomas, but within pediatric low-grade gliomas. It's present in many different histotypes and tumors of various aggressiveness. So it's neither prognostic nor diagnostic, but it's highly relevant to clinicians because we have very good therapies for targeting that specific mutation. So many of these alterations share in that phenomenon and make profiling these tumors highly useful, even if their behavior is by nature slightly more indolent. So there's been many efforts to try to construct an algorithmic workflow for testing in gliomas, whether they're pediatric or adults. And I've purposely picked this complicated algorithm to indicate that while there's many opportunities to pursue single gene assays based on where the tumor occurs or what it looks like under the microscope, the common denominator is that comprehensive sequencing of some point is probably going to be the highest yield, irrespective of tumor type. It will give you the most comprehensive analysis of all the diagnostic, prognostic, and therapeutic biomarkers, which are routinely needed not only for standard of care, but more and more for clinical trials and targeted therapies. So with that, I'll turn it over to my colleague, Dr. B.
Well, thank you so much, Dr. Meredith. It's a pleasure following your encyclopedic introduction to this topic. I'd like to present a little bit of the patient experience and timescale as we think about the practical application of tumor biomarkers. As a surgeon, I'm blessed to work with a multidisciplinary team in the treatment of central nervous system tumor patients of all sorts and varieties. The majority of these, especially in the malignant or aggressive settings, are those patients diagnosed with a glioma, as seen by this pie diagram of the common central nervous system tumors. However, there are many other pathologies, including meningiomas, craniopharyngiomas, pituitary tumors, and so on, which are increasingly seeing the power and application of biomarkers. So what happens when a patient gets diagnosed with a brain tumor? This can happen either what we call incidentally, because they bumped their head or had an accident and got a scan of the head, or because of a symptom. But regardless of the pathway, typically somehow a patient results with an MRI or a CT scan that shows an abnormality that is suggestive of a brain tumor. The clinician, along with the patient, based on the best guess, educated guess of what this is, needs to make a recommendation for treatment or observation. But usually only with surgery can we get tissue to make a diagnosis. From the point of surgery, the time to get a diagnosis, first with the pathology under the microscope, is about 1 to 2 weeks. And additional molecular diagnoses of markers, genomic sequencing, may take a little bit longer, often on the average of 2 to 3 weeks from the time of surgery. Collectively, that information is used by the treatment team, often comprised of the oncologist, neuro-oncologist, radiation oncologist, and surgeon, to then guide next steps of treatment, whether that be observation further or chemoradiation. And only with time, at this point in time, do we know ultimately what the clinical outcome can be. However, in the setting of aggressive or malignant tumors, even while we might be able to achieve a perfect outcome with surgery and radiation or both, often these tumors will come back. And hence, what to do, both in the upfront setting as well as on recurrence, becomes the major challenge for us in the neuro-oncology field. The concept of biomarker-driven clinical trials has revolutionized more tailored treatments for patients. This has been most apt and most widely adopted for glioblastoma and other sort of aggressive gliomas. In this example of an innovative clinical trial driven by molecular markers, the INSIGHT trial run by Dr. Patrick Wenya, Brian Alexander, Lorenzo Treppa, and Keith Ligon, we have newly diagnosed glioblastoma patients who, from sequencing of their tissue as offered by the ALLELE program, are then randomized to one of many arms that offer different types of targeted therapies, and with that, then are able to tailor the treatment to the specific molecular alterations in their tumor. This type of innovative adaptive design is aimed to be able to tailor treatments that are best suited for individual patients rather than one size fit all. The diagnostic workflow of the actual molecular testing is demonstrated by the schema here, in which the patient undergoes some sort of tumor surgery or a blood collection, or most likely both. And that tissue is analyzed through sequencing of various types, which then allows us to derive biomarkers, which can then guide the clinical trial enrollment. Increasingly, we also have biomarkers which may be derived from beyond the actual tissue from the tumor itself. This is a concept that is learned from systemic cancers, with that tumors may secrete either secreted DNA or tumor cells into the bloodstream. For the central nervous system, this is more difficult because of the blood-brain barrier, but we have increasing promise and signal that this is a viable path for the future. The application of liquid biopsy, or being able to discern tumor-specific markers from the blood and the cerebrospinal fluid, has had increasing applications for tumors such as CNS lymphoma, potentially meningioma, brain metastases, and as we learn more and more about their role in glioblastoma, we hope that this will allow a more powerful way to monitor both initial diagnosis but treatment response through the stages of a patient care. But having tumors being profiled is a two-way street. Not only can it help the patient, but it can help advance science, which then ultimately can be synergistic for the cancer field and future patients. So, for example, right now at the Brigham and Dana-Farber, we commonly ask patients about tissue banking, meaning saving any additional tumor tissue not used for diagnosis for potential future research. That tissue that's saved from the time of surgery can not only go into sequencing, which then can feed back into the clinical trials, as I just mentioned, but it can be used to create biological models that are more representative of cancer than artificially generated models, which ultimately can then cycle back into helping patients within their lifetime or in the very near future. This explosion of synergism between the generosity of patient samples, as well as the passion of our scientists to study those samples and derive new treatment algorithms, has really found great kind of application in several tumor types. I'll give the example of two tumors beyond gliomas, for which novel biomarkers have improved our ability to prognosticate and to offer treatment options. First, that of meningiomas, the most common central nervous system tumor, which is often thought of as being benign, but increasingly appreciated to also have more aggressive subtypes. In meningiomas, because of a systematic effort to study the molecular profiles of meningiomas that are operated at our institution over the past decade, what we've been able to derive is the fact that there are set types of molecular alterations. In this particular example, these are over 1,000 meningioma patients in which every single vertical tick mark represents an individual patient and each row represents a different chromosome. The presence of a bold color, blue or red, represents a molecular alteration in that chromosome. And you can see there are a number of patients with so-called benign grade 1 meningiomas that have just as messed up a pattern as those patients with more higher grade tumors. What that allowed us to do is to derive a molecularly integrated grading scheme for meningiomas, removing the classic histology and instead imbuing the molecular markers that we were studying to be able to better assess the prognosis of these patients. So in this cohort of patients who had discrepant WHO histopathologic grade compared to the molecular integrated grade, the so-called molecularly benign tumors that were WHO higher grade, aggressive or malignant, did actually far better than the so-called benign WHO grade 1 tumors that were molecularly aggressive, integrated grade 2 and 3. So this sharp contrast in patient prognosis as guided by molecular markers is a key example for how we think about these strategies improving future care. In another example, craniopharyngiomas, a tumor that can be locally aggressive in both children and adults. It was actually an accident in which one patient who generously signed up for molecular profiling, had their tumor tested and uncovered the observation of this mutation called the BRAF V600E mutation, often found in low-grade gliomas, especially in the pediatric population, that then when we investigated many more tumors was found to be a pattern in 95% of these cases. And that led to the initiation of a successful clinical trial led by Dr. Bracianos, which then showed that the application of this drug can significantly decrease the tumor burden in these patients. Now, this does not necessarily remove the fact that when a young patient comes in with visual symptoms from a craniopharyngioma, we can still offer standard of care treatment, including surgical resection to alleviate their symptoms and improve their functional outcome and their chance for cure. But it opens a vast door for potential future options in which if this young patient were to recur at any point in the future decades of their life, we have an additional tool in our arsenal, which is that of a drug therapy beyond surgery and radiation. So all of this is made possible because of the initial patient generosity to allow for tissues to be banked and to be studied molecularly. And as we move into the future decades, this can only be more and more powerful. So thank you very much.
Thank you both for your outstanding presentations. They were comprehensive and I'm sure go a long way to inform our patients and caregivers. We've gathered some key questions from our community in terms of helping them to better understand biomarker testing and their own individual journeys. The first question is, what should a patient do if their hospital does not offer them biomarker testing?
So I think probably the best thing to do, the oncologist can certainly request that their material be sent to one of the commercial laboratories, many of which can provide service free of charge depending on the financial needs of the patient. Caris, Tempus, Foundation One, all are excellent labs that can provide this testing. The other thing is that if at some point in their care they end up choosing a second opinion or referral to another cancer center, whether it's a higher volume center or a different one, that laboratory may be able to perform that testing as part of their second review. So there are a number of options available to them, and I think that's something that should be easily available to them.
Great. The next question from our community is, how would a patient or caregiver learn about clinical trials that would be appropriate for either their tumor or their child's tumor?
Okay. There are a number of resources. Clinicaltrials.gov has a compendium of all available clinical trials, both ongoing as well as potential future listed trials that are about to enroll as a central resource for patients. But probably most importantly, just because a trial seems appropriate or may not seem appropriate, it may not be tailored necessarily to the individual patient's circumstances. So we strongly advise that patients speak with their oncologist, their radiation oncologist, their surgeons, their treatment team to discuss this. Many patients are, especially these days, are so well educated in online forums. And so there's a lot of dialogues, and including these social media platforms that can share experiences. Second opinions are quite common across the platform, and with the Zoom platform and other sort of virtual platforms, it's increasingly more convenient for patients to seek opinions across the nation. I think ultimately there's no single answer for any individual patient, and that any decision should be guided by their clinical treating team.
Okay, thank you. Dr. Merritt, I feel like you answered a bit of this in your first question, but just very quickly, for those that are looking into this, how can they get a sample of their tumor, or again, their child's tumor, tested for biomarkers to learn if in fact there are targeted therapies that might be able to treat their tumor type?
Sure. So I think there's a couple of opportunities. A lot of these requests can be handled, either directly from the patients or from their treatment team, reaching out to us and pathology to send those samples to another center if they wish to have testing performed somewhere else or at a commercial lab. That's something that's routinely done, something we do on a daily basis.
Thank you. A question that actually our own personalized support navigation team has dealt with before is, can they have their tumor tested or their child's tumor tested now if it wasn't done in the initial surgery?
Absolutely. Yeah, that's something that, again, is something that we do almost on a daily basis here because as the knowledge continues to expand, I mean, the discovery of these biomarkers we discussed in the presentation today are, in many instances only a few years old, and so there's many patients whose initial surgeries happened well before that, and we can retrospectively examine those just as we would on a routine case that comes in real time. So that shouldn't be something that stops anybody from testing.
And do either of you know or have any experience in terms of the insurance piece of this? And does insurance cover costs for biomarker testing?
That's a great question. It does, but for select tumors, that is something that should also be addressed with the individual treating team. So increasingly, insurances will cover testing which can impact treatment. And so some of that, including glioblastoma, lymphoma, lung cancer, and so on, are covered. This could also vary from state to state. Others are in the evolution, and we hope to be covered in the future. The power of having large kind of cancer centers and institutions that very frequently, even when testing is not covered by insurance, there will often be trial options that will cover the testing as part of the research process. And so we encourage patients who are interested in this to speak with their providers because there's an insurance avenue. Sometimes there's actual state programs that allow for free molecular testing in certain states, as well as institutional resources that can help with this.
Thank you. Dr. B and Dr. Meredith, thank you so much for joining us today. We appreciate you creating meaningful content for our community and answering those key questions to help our community better understand biomarker testing and how it may impact their treatment.
Thank you so much. It's been a delight joining both of you, and we're so delighted that this program can be made available for patients.
Thank you for having us both. It was a great opportunity.
I also want to thank our community for watching Informed in 30, Understanding Biomarker Testing. We hope you will watch our next segment coming out in September about managing quality of life care in pediatric brain tumors. Thank you so much for joining us.